Our next speaker is a top surgeon and a prolific author. He has published widely on patient safety and helped the World Health Organization develop quality measures. He's known in the medical profession and in the news media as a no-nonsense, nonpartisan advocate who uses science to highlight the need for transparency in healthcare. Please welcome Marty Makary.
When I was a student, I was told I need to pick a required foreign language. The options were Spanish, French, and Latin. I didn't know what to pick, so I went to my advisor and asked, what language should I pick? And he said, well, what are you going to go into? And I said, I don't know, I'm thinking about maybe going into medicine and being a doctor. And he said, Latin. I said, does anyone speak Latin in the world? He didn't know, but he said, look, everyone who goes into medical school takes Latin. That's what you do. So I went to my local hospital, Geisinger, and I found a doc that I knew, a friend of the family, and I said, what language did you take? And he said, Latin. And so I enrolled in Latin, the required language, and for that year, took exams every week, Agricola, Agricolae, Farmer. And year 2, year 3, year 4, 4 years of Latin, I thought, man, I'm going to be ready for medical school. And I get to medical school, and I'm sitting there in the lecture, ready for this first lecture, ready for the Latin, and there's no Latin. And my enthusiasm deflated, and I realized, where's this big advantage? And a year and a half into medical school, a Latin word came. And I said, gosh, I know that word, necrosis, dead tissue, necrosis. And I recognized it like 1 nanosecond faster than everybody else in the room. Meanwhile, I can't communicate with about 10% of my patients who only speak Spanish. But I know that word. It comes up in conference every now and then. They'll say in conference, the patient had necrosis, and I'll say, yes, I know that. And then I look around, everyone else just memorized the word. And I kind of almost get angry that I know that 1 nanosecond faster than my peers. And at some point it hit me, this intense frustration that we have in healthcare, that we're not lazy people. We just don't want to spend our time on things that don't matter. What matters to patients? What matters at the bedside? Now, how many times did we learn the Krebs cycle, the 12 intermediate molecules? Every class of the 14 years of education to do what I do today in surgical oncology, I learned that Krebs cycle. It doesn't matter for what I do. And there's this intense frustration. Meanwhile, we spent 0 time in education learning how to break bad news, something I got to do every day that I'm still not great at it. I'm still learning after 15 years. What matters to patients? Is it the things that we find are easy to measure, or is it something else? I had a patient ask me, now, doc, after the surgery, what about after? And I quickly go into my scientific mode and I say, well, the risk of readmission is 25%. The pancreas has no capsule, so anytime it's manipulated, it gives off fluid, and fluid collections develop, and 1/4 of the patients are readmitted, and half the patients develop some complication, manageable and minor. 1% of the time it's serious, the readmission rate to the ICU. And he said, whoa, doc. When can I mow the lawn again? And it struck me that what patients think matters is different from what we've said matters. What matters to a patient, in my opinion, is not the infection rate or the readmission rate, which has a lot of contributing factors, some of which we can't control, and of which there's a lot of noise, and of which we're really measuring what happens after we do something. The patients want to know, do I need what you want to do? Do I need that prescription? Do I need that diagnostic test? Do I need that operation? And what makes a good doctor is not their outcome metrics after doing things. It's their judgment, their skill, and their honesty to say, I don't know when we don't know something. And number one, sound medicine is defined by knowing the appropriateness of medical care, the appropriateness of giving that prescription. 10 years ago, we gave out 2.4 billion prescriptions. We doctors gave out 2.4 billion prescriptions. Last year was almost double, 4.6 billion. Did disease double in those 10 years? No. What we have in the United States is a crisis of appropriateness. The number one issue in healthcare today is the appropriateness of medical care. It is the number one driver of the cost crisis. It is the number one opportunity to fix our broken healthcare system. As people get crushed with their premiums and everybody's outraged at the costs, listen to the voice of doctors as we did in this study, asking them, in your opinion as a practicing physician, what % of medical care is unnecessary? Here's what they had to say. National study, 21% of medical care is unnecessary. This is the voice of doctors. Now, in any industry, if 1 out of 5 services rendered were considered wasteful, we'd say we need to find a way to measure it and we need to address it, right? Yet what we do in quality is we develop these measures through a long process where we insist on all of these publications first, as if we can't listen to the voice of frontline people in healthcare, and we say, okay, this happened, this knee operation happened. Now, what was the rate of readmission and what was the rate of infection afterwards? You know what the rate of infection is after a knee replacement, by the way? About 0.3%. And we're going to say if you're at 0.2%, good job. And if you're at 0.6%, try to do better. And we fool ourselves into thinking we're measuring value in healthcare, the hottest word in healthcare today, value. Appropriateness is the number one opportunity in healthcare to fix the broken system. Now, we got a Robert Wood Johnson Foundation grant to ask, can we create a new generation of measures that are not this happened, now what's the outcome, but instead asking what's the appropriateness of the medical care? And instead of fighting at the individual patient level, that is, the doctor did bad because we didn't follow a guideline or we were compliant or non-compliant with a practice at the individual patient level, or we shouldn't get the MRI on this one patient, and we have this war with the payers. And we say they don't understand and my patients are sicker. And hospitals get all this data and look at it and tell me, what do we do with this data? We have all this data. I don't know, feed it back to the doctors, they say. And the doctors look at it and say, these aren't good measures and my patients are sicker. And the whole field of quality is stagnant at this level. But what if we looked at an entire physician's practice as we did in the first rendition of these new generation quality measures? And asked, for example, in the first one, getting skin cancer surgeons together, asking, tell us about waste in your field. And the Mohs surgeons, those that resect skin cancer in blocks, they said, we get paid per block. Most doctors do the right thing and always try to. I firmly believe that. But they said there's a group, outliers, that are charging all this money by taking out unnecessary blocks. And they said, look, on average, you should take out maybe 1.5 blocks in your practice. 1 to 2, rarely a third block should be removed. And we graphed it nationally, and sure enough, we found massive variation. Most doctors do about 1.5 blocks. Most doctors do the right thing and always try to. But they set boundaries of what's considered reasonable variation. And they said those outside of those boundaries are practicing in a way that is indefensible to their peers. A whole new type of quality measure, because we're not looking at a patient level, we're looking at the physician practice level. We're accepting and endorsing variation, but we're saying let the experts set the boundaries of what's reasonable variation. Every Mohs surgeon in the country got this report generated by our research group, at Hopkins, and the Mose College sent a cover letter. They sent it out saying, hey, this is where you stand. This is where the rest of the doctors in the country stand. If you want to talk about this or some retraining options, let us know. If you have any feedback, let us know. And so the emails started coming in. But the emails said, not what you're expecting. The email said, thank you for letting me know. I didn't realize I was an outlier. I'm going to try to do better. This is an important project. Out of hundreds of emails, none of them were critical of the measure or negative. Why? Because we engaged physicians on a peer-to-peer basis that was civil, using a doctor-endorsed measure that embraced variation and didn't condemn it. It simply set boundaries for that variation. And so the project, wildly successful, has expanded now. We have over 150 measures in almost every specialty of medicine. We've got measures in physical therapy and spine surgery, the percent of your elective spine operations where the patient had at least one physical therapy visit in the year before spine surgery. Doesn't need to be 100% of your patients, but it needs to be at least half, according to the spine surgeons. If you're operating on patients that rarely try physical therapy once, the docs tell us that is the surrogate marker for inappropriate spine surgery that goes on in the community. The number of biopsies during a screening colonoscopy, if the code is for screening, then how can you justify doing biopsies at 4 times the rate, or nearly everybody getting a biopsy when the national rate is 20 to 30%? And so the metrics started to march out. In pediatric surgery, umbilical hernias, they close on their own, the things we call outies. They close on their own by the time the kid turns 5 or 6. But what proportion as a pediatric surgeon of your umbilical hernias is in kids under 5 with no other combination procedure? These are the markers of appropriateness, getting at that question patients are asking, do I need this medical care? If, in fact, 21% of medical care is unnecessary, this is the opportunity. This is the opportunity. Public health crises come in 2 forms. There are manufactured crises and there are naturally occurring crises. There are manufactured healthcare crises and there are naturally occurring viruses and disasters in the environment. Most of our public health crises today are in fact manufactured. If you look at the #1 public health crisis, according to the WHO, it's antimicrobial resistance from overprescribing. And I would add to that routine use of antibiotics in agriculture. That accounts for 20% of the resistance we see in hospitals, not even on our radar. Medical errors, the byproduct of our complex medical system. Too much medical care, double the number of prescriptions this year, and the cost crisis, a manufactured crisis, something that's been a byproduct of our both amazing yet complex and sometimes messy healthcare system. And one that has been so emotionally difficult to watch, one that's affecting our kids, and in the last several months so vivid to those of us that know of some neighbor or patient or friend or kid that's been affected by an avoidable death from opioids. This is a man-made, manufactured crisis because we doctors have prescribed and continue to prescribe 1 opioid prescription for every adult in the United States. We give them out like candy. I gave them out like candy. That's what I was taught to do. I was taught that way you avoid patients calling in the middle of the night. You avoid pain. They're not that addictive. Just, give out 30, 60. I didn't know better. And so we've graphed using the practice pattern measures for a standardized procedure like a gallbladder removal laparoscopically, one of the most common procedures in America. How often do we give prescriptions? And what's the average number of oxycodone pills we give? And look at this. It's the Wild West. We should be giving 10 or less opioid tablets when somebody leaves the hospital in a narcotic-naive patient not exposed to opiates and no chronic pain syndromes. That's the vast majority. Say for C-section, The vast majority of common procedures in the United States, we've got a website now, solvethecrisis.org, where we're saying these are the best local practices. Why are we giving 30 and 60 tablets routinely, flooding the community with this dangerous medication? We're using a practice pattern measure to address the root cause of the problem, too much medical care. Another version of too much medical care. I've tried to put these appropriateness measures into the market. Oliver Wyman, in a partnership, is running these appropriateness measures for health systems. There's the question, what percent of medical care is unnecessary? 21% in a study that we just published. In a new network called Visa Health at visahealth.com, we're telling doctors, if you believe in appropriateness and you're with us, let us talk with you. We will engage with you. And if we believe you are as passionate about the overtreatment problem and deliver state-of-the-art sound medical care, we would like the market to reward you, and we want to send patients your way. Employers and TPAs that are looking for sound medical care can get access to these doctors that shouldn't be punished for doing the right thing. They should be rewarded. Finally, I had a patient that I made a mistake on. I ordered a test on somebody and it got done on somebody else. The guy that it got done on, we didn't have a great rapport. He didn't like me. And I thought, gosh, this is the worst person for this test to get done. I don't know what went wrong in the transmission of communications. And I went immediately to that patient and I said, look, I know you're not going to like to hear this, but that test you just had, the CT scan, was a mistake. I take responsibility. I'm sorry. If you want me to get the results, I'll share them with you. That patient didn't sue me. He looked at me and smiled and he said, Doc, thank you for being honest with me. I really appreciate the fact that you came up here and shared that with me. And it struck me, patients are hungry for honesty in healthcare. That patient never sued me. In fact, we are Facebook friends today. Okay? Patients don't care how much Latin we know, how many times we memorize the Krebs cycle. They don't even care about some of the traditional quality measures that we've been ingrained define us as a doctor. What defines us is our judgment, our skill, our humility to say, I don't know, and number one, our ability to recognize when medical care is appropriate. Thank you.